We had a wonderful educational symposium at ESMO this year looking at luminal early breast cancer with 3 talks. And my role was to give an overview of neoadjuvant therapy. And basically, I discussed neoadjuvant chemotherapy and discussed briefly neoadjuvant endocrine therapy, and then a short preoperative endocrine therapy in order to see whether patients have endocrine responsive disease. So with regard to neoadjuvant chemo, I think the most important thing is that it's safe to give. We have outcome data from the early breast cancer trialist group that it's as good as adjuvant chemotherapy. But in luminal breast cancer, the critical point is that we should only give neoadjuvant chemotherapy if we would give an adjuvant chemotherapy in the same situation. So establishing the chemotherapy indication, I think, is key in that setting. And we can do this with the gene expression assay together, drawing from our ADAPT and ADAPT cycle experience with endocrine response assessment. In order to have a neoadjuvant chemotherapy indication, we need to do the gene expression assay from the core biopsy. And there's, for example, for Oncotype DX, there is ample data that gives comparable results. And in our ADAPT experience, we had about 95% feasibility of doing an Oncotype from a initial diagnostic core biopsy. So once the chemotherapy indication is established, I think our standards are anthracycline, taxa, and sequence. We want to give that in a dose-dense fashion that is preferred based on the Oxford overview, but also on the data we saw at ESMO from the GYM2 trial from Italy. For patients with an intermediate clinical risk, up to 3 lymph nodes, we can also use 6 cycles of docetaxel cyclophosphamide. There is a pooled analysis from 2 large German trials, almost 6,000 patients, comparing 6 cycles of TC to a sequential, conventionally dosed anthracycline taxane regimen. And we did not see any difference in the luminal A or luminal B patients. The only difference we saw was favoring the anthracyclines in patients with a large volume disease that is 4+ involved lymph nodes. So anthracycline taxane sequence would be our standard, but for patients where we don't want to give the anthracyclines, 6 cycles of TC in that intermediate clinical risk category would also be a good opportunity. And our German guidelines state that if we have a chemo indication, we should preferably give it in the neoadjuvant setting. I think that's also true for luminal breast cancer, because we can tell patients what the further therapy is going to look like, and we have sort of an estimate about their prognosis. Lastly, our new adjuvant agents in order to increase the chances for cure, like Abemaciclib or Olaparib in the germline BRCA mutation carriers. There's also data from both registration trials after neoadjuvant chemotherapy, and those patients also derive a substantial benefit. So I would say that if we're sure about the chemo indication in luminal early breast cancer, please give a chemotherapy in the adjuvant, in the neoadjuvant setting. If we're not so sure and we feel that if we do the endocrine response testing and then do surgery first in those patients, we have a more complete picture about whether there's really a chemotherapy indication, then obviously adjuvant chemotherapy is also one of our standard options.